I'm sure already you can see that there's a slight theme to what PharmAccess is doing now. And that is not just working with the individual clinics, but actually also working with the regulators. Because without the regulators, all the work PharmAccess is doing in the field would not have as great an impact as we would want. Sir, considering the uniqueness of PCN, we know you regulate both the practice and the professionals in the pharmaceutical space. How is PCN able to regulate all these categories of providers, from the pharmacists, pharmacy technicians, patent medicine vendors, marketers, manufacturers, distributing outlets, and manufacturing plants?
The Pharmacists Council of Nigeria, perhaps, before I talk about the Pharmacists Council of Nigeria, what is even regulation? What is it all about? Regulation revolves or involves setting standards, ensuring that the standards are followed, and where there are breaches of these standards, you carry out enforcement. The time will not permit us to go into all the story as it relates to us as Pharmacists Council. But let's state that the importance of regulating the pharmaceutical sector predates Nigerian independence, because the first law that regulated pharmaceutical sector was in 1887 and was called the Iroko laws. Then the target was to ensure essentially that those bringing in medicines into Nigeria, as they travel along the coast of our oceans, bring in medicines that are qualitative, that are effective, and that are safe. That was fundamentally why the Iroko of 1887 was established. Then it came to 1902, and then it kept coming that way till we had independence. We had the Pharmacists Council or Pharmacists Board of Nigeria law of 1964, and then till we have the Pharmacists Council of Nigeria that we operate now, starting from 1992. Having established this foundation, and also having established and acknowledged the fact that our responsibility is to set standards, ensure that those standards are followed, and where there are breaches, we enforce. The question now is, where are we where we are? We regulate a broad spectrum of activities, personnel, practice, and facilities. From the pharmacist's point of view, I can say, from the time we were set up till today, we have done well. Today we have on the register about 25,000 registered pharmacists. On the part of the pharmacy technicians, it started well, but again, we came to a situation where perhaps today that we have realized the need to do things right, we will change. Or let me even say that we have changed. We had a situation where the pharmacy technicians who are subcadre of the pharmacy profession were being regulated. And this is a global practice. It was said here that regulation is a global standard. Came up, went to court, said they don't want to be regulated, and they wanted to establish their own facility. The question now is that in establishing or parting away from pharmacy profession or the pharmacist, what are they advocating to do? Are they advocating to now begin to manufacture drugs? Are they advocating to now begin to import drugs? Are they advocating to now begin to distribute drugs? And then, do they have that capacity by their training? Unfortunately, we had a court that granted judgment in that favor, as sad as it is. Again, we come to the patent medicine vendors. The patent medicine vendors were crashing of the laws of the Federation. Today, the law that created the patent medicine vendor is far back as 1936, and that is Cap 152, LFN, 1990. There was a justification for the creation of this category of individuals. The justification was there was insufficient number of pharmacists, there was poor distribution of pharmacies, and even health facilities. And then we needed to take service or medicines closer to the individuals. Let me give us the worst scenario situation that I think has never happened in the regulatory space of any country. It was between 1936 and today, over 80 years, the Pharmacists Council had to be asked by authorities that hands off the regulation of the patent medicine vendors. Sometimes they give it to Federal Minister of Health, when indeed they are not supposed to be regulatory institutions. Sometimes it was given to the state ministries of health. And the worst came in 1990, when the authorities under the military delegated the issuance of patent medicine vendors to the local government. Not until 2003 again, when it came back to the Pharmacy Council. And then we put in place a process to ensure that we get things going right. But as you can't believe it, as you expected, people have benefited from this process. Before we knew, not up until December 2015, we were going to 51 court rooms because different groups had come up to resist regulation. Thank God again, today we have overcome that. So, now we are talking about marketers. Where in the world do we have marketers selling drugs? We are not supposed to have. Today we have, because the space, regulatory space, had been interrupted at different times. But good be as good as bad as all these pictures look, one thing is key: strong legislations. We have the support of the immediate past Honorable Minister of Health. We now have a new Pharmacy Council bill that will make all these disruptions impossible moving forward within the pharmaceutical sector. As we move forward, we'll talk about those things in the bill. Thank you very much.
Thank you very much. Dr. Idowu is the Executive Secretary of the Health Facility Monitoring and Accreditation Agency in Lagos. Lagos is the center of excellence. And of course, I think many states actually look to Lagos for direction and learning. We know Lagos has the highest number of health facilities in the country. There are over 3,500 health facilities, of which about 3,200 are private health facilities. So we'd like to know what strategies you have in place to improve the regulation and quality of healthcare service delivery in Lagos State.
Thank you very much, Dr. Dada. A Pharma, as an acronym, was established in 2006 by the Health Sector Reform Law to ensure that standards were in place and to ensure compliance and evaluate performance of these standards. Currently, a Pharma has on its register 3,399 private health facilities and 335 public health facilities. In 2015, an institutional capacity of the agency was done so that we were to ensure that we're able to fulfill our mandate of ensuring compliance to set standards, and a few gaps were identified. And we also articulated strategies to bridge the gap. One of the things that we did after the institutional capacity was to do a mapping of all health facilities in Lagos State. This mapping was supported by PharmAccess. And the main reason why we did the mapping was to identify registered facilities and then identify those facilities that were not registered and operating illegally, and those that were operating below standard, and then for us to, engage with those facilities that were borderline and try to improve the quality of their service. In addition, we also realized that we needed to review our standards, and currently that is ongoing. At the end of the day, we're hoping that by the time we will finish reviewing our standards, we would bring it up to one that is internationally acceptable and one that is outcome-focused and result-oriented. We also reviewed our quality assurance tools, our monitoring checklists, so that we're able to, monitor appropriately, because before, and then we broke the checklist down into the schedules so that we're able to monitor all the services that are being carried out at both public and private health facilities. We have also deepened our engagement with professional associations. One, we want to encourage them so that they start regulating themselves, because we know that it's only when they regulate themselves or when they have the desire to regulate themselves that they can actually improve their quality. Regulate themselves in terms of clinical audits, having the desire to improve themselves, and continuously carrying out quality improvements in their facilities. We also, engaged and we're continuing to engage with other regulatory agencies. One, we're doing that so that there won't be duplication of efforts, and then so that other, healthcare providers will not be hiding under different regulatory agencies to say, and being regulated by NAFDAC, but they are carrying out activities that are way beyond their scope. For example, we have pharmacies who give patients infusion in their chemists. And because they are basically not under us, we need to engage with the pharmacists so that they regulate them and penalize them when possible. And we also carried out, we introduced what we call ePharma. It's a platform for registration and licensing of health facilities. It makes the registration and licensing an easy process, and then it reduces the time that we use in processing their registrations and licensing. And then it also, reduces the number of times these healthcare providers have to come and visit us to say they want to be licensed. We say now, do your registration, do your renewals, do it online. Don't worry, we'll come to you. When it comes to giving the certificates, we'll give you when we're carrying out the monitoring visits. We currently have about 113 health facilities on the platform now, waiting to be registered. Of course, we also tried to improve ourselves as an agency. What do I mean by that? One of the things we did is we re-articulated our vision that we want to be a reputable agency, a reputable regulating agency, improving quality of healthcare in Lagos State. And in doing that, we shared the vision of this, we shared our re-articulated vision with the staff so that everybody is on the same page. We all know that we're working towards the same purpose. In doing that, we also re-articulated our core values. We say, as an agency, we want to be professional. We want to, carry out our services in such a way that we would execute excellence. We want to work as a team with the professional associations. We want to be accountable for our actions. And we want to carry out everything we are doing, showing integrity. Because as we all know what, regulation is and the risks that it carries when it comes to accountability. So we want the healthcare providers to see us as people of integrity. We want to speak and let them know we're not out to witch hunt, where we want to work with them to improve the quality of their service. I would say that in all of that, we have had challenges. We have some that are internal and some that are external. And I'm going to start with the internal ones. Funding. We know that regulation, when it comes to regulation, it is not cheap. And then having the appropriate staff who would carry out these activities is not also, something that is something we are working on. It's something we're constantly trying to improve. And believe it or not, another major challenge that we have is balancing our regulation with trying to, carry out supportive supervision. We want to, the line between when you want to say you have done this, you'll be penalized, and when to say, okay, you have done this, stop doing it. We want you to improve your service. So that's also a challenge for us. And also litigation. We're having a lot of litigation these days. For the external ones, where most of us are doctors, most of the offenders are doctors. Quackery. I'm not saying doctors are quacks, but I'm saying that we employ people who are not qualified in our health facilities. We also engage in acts that were not licensed to practice. It's a major challenge for the agency.
So now we're moving to Adamawa State. This is another state that actually blew my mind. In some states where we work, you probably would be chasing the government, but Adamawa actually keeps us on our toes. Where are our deliverables? Where is this? We're waiting for this document. So we're extremely proud of Adamawa. Dr. Attahiru Bello is the BHCPF desk officer, but he also has so many caps, wears so many caps in Adamawa State. But I think he's here today as a representative of the state quality team. And one thing I can say is Adamawa actually approached PharmAccess for support, which we have been doing in the last close to 2 years, a year and a half, I think. And one of the things we tried to do with them was around their scheme design, as well as harmonizing their quality and regulatory system. So, Dr. Attahiru, Dr. Bello, please. I would like you to talk about the state regulatory and quality system prior to the harmonization process. And at the same time, we would like you to talk about the harmonization process, what you have done since that harmonization, what lessons you have learned, what your challenges are, and what the next steps essentially are.
Thank you so much. First of all, I would like to mention that Adamawa State is one of the pilot states for the NSHIP PBF scheme. And the National Health Facility Survey in 2016 has placed Adamawa State as the first and Ondo State second. These are all NSHIP states. 77% of our health facilities, primary health care centers, have got the basic equipments as far as the PHC is concerned, followed by Ondo State. So the SOML, when it came, the National Health Facility Survey 2016 was used as a baseline. So after the first year of implementation of the Saving 1 Million Lives, Adamawa State emerged the zonal champion. So we felt these projects all have checklists which is used in monitoring their activities, in monitoring and evaluation process. So we felt harmonizing this checklist is a step towards ensuring a kind of a sustainability plan and consolidating the gains instead of having so many checklists. For example, we have quality checklists at the LGA. We have quality counter verification done from the state to the LGA. We have the integrated supportive supervision checklist separate, which is usually used by the State Ministry of Health through the SOML. And then we have other maternal and newborn child health checklists. Checklists are usually designed for the purpose which they are intended to. They provide feedback, agreed, yes. But some checklists, you know, they look at different measures, output, outcome. Some of them, they look basically at equipments. Some of them look at community, maybe client satisfaction surveys and others. Yes, they all give results, but they are all for the sake of quality. So we approached the PharmAccess for support. What we wanted was to harmonize all these checklists. The beauty of it is we leverage, the PharmAccess leverage on the already existing structure, the existing quality team to actually develop this checklist, to harmonize this quality checklist using local content and ideas, bearing in mind our context, bearing in mind what we really want. You know, so we are not, we were careful not to create another parallel system. So we were able to integrate all these checklists and digitize them. It is an app, the quality assurance tool, and it's found on the Google Play Store. The app has an ability to also segregate the results according to domains. It is able to provide feedback for the team, for the health workers, and up to the level of the community to the WDC chairman in the community, at the community level. Community ownership and participation is key and is essential for a strong primary healthcare system. So we were able to segregate the results because it is, of course, a digital app, and also inform the community of our findings, especially during quarterly steering committee.
FMC Ebute Metta has transformed, considering the challenges of the public sector in terms of staff shortage and attitude, poor funding and infrastructure. Everyone would like to know the enablers of this transformative change.
I was like an outsider. The administration was already set. We had the head of admin in place. All the top management committees were already in place. So I was like the outsider brought into administration. And you had these guys already who were used to doing things in their own peculiar way. So I had to sit down to carry them along. And at the end of our process, it was quite obvious to us that if we're going to be able to make any difference in the system, we needed to fix our financial system. We're selling drugs, huge volume of drugs. We're, running laboratory tests and doing our x-rays. But at the end of the month, when it was time to pay these guys, the vendors, you just find out that simply that there's no money to pay them. And that had led us to lose credibility with the vendors. They weren't supplying us, and that was affecting the quality of service that we were rendering, because if they stop supplying you drugs, then the patients go into your pharmacies and they can't get drugs, okay? They go into your laboratory and they can't run their test, okay? So it was obvious to all of us that we actually needed to fix our financial system, at least as a first step. And so basically what I did was, or what we did was, one, to ensure that none of my staff touched government money any longer. Fortunately for us, the federal government introduced the TSA, so we brought in the remitter agents into our institution, and then we brought in the POS system. But I also needed to be very smart about it so that we don't generate labor issues. And I'm sure we all know what labor issue is in the educational sector and in the health sector. Okay, So what I then did was to make my staff the policemen of the people who are going to be collecting the fund. Okay. Initially, there was understandably a lot of resistance. But at the end of the month, everybody was pleasantly surprised. When we wanted to introduce this, I was looking forward to maybe initially 10, 20% increase or whatever in what we're generating. But at the end of the first month, there was an 100% increase. And so, you know, so I was quite happy, and the staff too were very happy, all right? And at that point, I realized that the team, that is the team pushing the process, we needed to be careful. So we brought in the staff to be part of the process, okay, to determine how we're going to expend this new, in quote, windfall. And we realized that the first thing we need to do is to reintroduce credibility into our system. We are owing our vendors huge sums of money, some 3-4 years. We have not paid them, and so they have refused to give us products. And so gradually we started repaying these guys. And then, of course, the vendors were happy to actually now start giving us new supplies, okay? And so you then go to our pharmacy, the drugs that were not there previously became available. We could run all the tests. Patients didn't need to go outside the hospital. And then we can run our radiological services, okay? And so with this new improvement in this particular reform that we did, it actually encouraged a lot of the staff. And then we then started looking at the quality of our services. Because as at that time, we were supposed to be a 230-bedded hospital. We had lost almost about 70 of the beds to either leakages, water leakages, the rain is falling, the patient can't stay there, the beds are not good. And so gradually, in a systematic manner, we sat down, we had a strategic plan, and then we started tackling these issues one after the other, okay, with our new improved resources. And then we opened it up for everybody. We ensured that we got value for money. We didn't hide anything. We encouraged the staff to actually ask us questions. We had staff, we introduced staff forum. So now to the staff, you talked in your question of poor staff attitude. I actually don't agree. The general feeling from those of you from the private sector is that once it's government, then it can't be good. I don't agree. I know that the staffs have some challenges. They probably don't have capacity to deliver in some area, and that is one of the things we have been doing to improve their capacity to deliver. If you go to most of the government hospitals in this country, they close their GOPD at 3 p.m., but our GOPD does not close until 8 p.m. every day, including Saturdays and Sundays. All right. If you go to our physiotherapy department, we don't close until 8 p.m., including Saturdays, all right? And it's this same staff. I think the issue basically is to have a leadership or a team, okay, that manages the process that the people have confidence in, all right? And then when we started doing all of these things, we then realized that we also had, I don't want to call it knowledge gap, capacity gap, okay? All right, and that was what brought us into the PharmAccess Foundation. Initially, they were providing us support informally, and it got to a point that we realized that to move forward, we needed to have a structured program. And so we brought them in, all right, and with their expertise, they have been able to help us, and I think we are flying now. Okay. So.
Thank you very much. I am always excited to see Dr. Onyia because every time Nigeria does a first, we celebrate the first. But the question is, after the first, what next? Dr. Onyia's hospital, Palon Memorial Clinic, was the first SafeCare Level 5 hospital in Africa. But since then, we have not had another one. Kenya has overtaken us by probably about 12 Level 5 hospitals. So the time is now for each healthcare provider to really start looking at their processes and start thinking of how they can improve on those processes. So Dr. Onyia, you're obviously committed to delivering quality healthcare to your patients. You're one of the hospitals that actually paid for SafeCare consultancy services. What has been the benefit of participating in the SafeCare Quality Improvement Program? And what advice would you like to give other private health facilities?
First, in 2010, when I started my practice, I went for emergency care training in South Africa. And I went to a hospital, the Chris Hani Hospital in Soweto. And I saw something on their notice board that talked about high reliability, getting it right the first time, every time. That stuck in my head. Also, I read another book by Michael Porter, the strategy guru, on, I think it was value-based care, redefining healthcare, value-based care. And that also stuck in my head. So when I started my practice, I recognized that one of the most important things I needed to do was provide service of a certain quality, highly reliable healthcare. I luckily am a trustee of PharmAccess Foundation, so I've been part of the PharmAccess journey since they came into Nigeria in, I think, 2002 it was. So when I started my practice, I realized we needed our hands to be held, to go through, for me to be able to share my vision with the rest of the team. So in 2015 or 16, I think it was, I engaged PharmAccess to come help with the SafeCare accreditation. The truth is, we could not afford it at the time. But like Dr. Coker had said earlier, if you think quality is expensive, try the alternative. So I recognized that it was a priority. So I remember the very lenient payment terms I got from PharmAccess. We paid maybe 4 times. And when they came in and did the baseline survey, I think we came in at a level 2. So we were hoping for a level 3, and with a stretch, maybe a level 4. So it was, wow, unbelievable when they told us we achieved a level 5. It was one of my proudest moments in life, and I'm very grateful to PharmAccess. And it's made a big difference. There are a couple of things Dr. Coker said when he talked about accreditation, and I think we should all take note. I did. He said licensing is about instituting minimum standards. Accreditation is maximum standards. It's actually aspirational. So, yes, we achieved level 5 in 2016. Am I 100% sure that if you come back again, we are still at level 5? No. So there's a need to continuously improve on quality. And I must say it's made a big difference. I was very proud when I saw the report of a survey that was conducted by an international body for an oil company talking about health insurance companies in Nigeria. And then they listed hospitals, that if those hospitals are among the provider list of those health insurance companies, then they are good health insurance companies. I was very proud to see Pelon on that list, considering we are only 9 years old in the market. Of course, the big guys like Laguna and so on were there, but it was very gratifying, and I'm sure all this would not have happened if we didn't go in for the SafeCare accreditation. So to answer your question, I will recommend accreditation of some sort to every private or to every health facility. The first panel discussion was on public-private partnerships for primary health care. And I must say that Delta State government is the first government that had achieved this. And the SafeCare accreditation we had in Lagos has made it very easy for us to be able to replicate the same thing at primary care level remotely. So I'm based in Lagos, but I'm already running a primary healthcare facility for Delta State government in Amai, Ukwani local government. And it's very simple because, yes, we have the processes, we have the policies in place, and we simply just replicated the same thing. So it's very scalable. So I recommend it very highly.